incredible, really great scores on his steps he have already matched in this match cycle. And let him introduce himself in a detail. So let's just wait for him. He have just texted me. He'll be joining within a couple of minutes, right? Yes, he's here. Hello, Dr. Muaz, are you here?
Yes, I'm here.
Okay, perfect. So we have Dr. Muaz, already told you guys. Okay, can you just please fix your mic? Okay. So as I already told you about Dr. Muaz, so he's here. So Dr. Muaz, can you just please give them a brief introduction of yourself? Okay, just let me just open my screen. My slide. Just give me a second. Can you guys just see my screen?
Yes, the
Okay, perfect. Yes, Dr. Muaz, can you just please start your introduction to our students?
Hello, everyone. My name is Dr. Muhammad Muaz Mushtaq. I'm an international medical graduate from King Edward Medical University, Pakistan. I recently got matched into Rochester General Hospital, which is a very big hospital of New York, and it is a very well-known and coveted institution for internal medicine. I have been tutoring for the past 4 years, and I have a lot of mentees who have tutored under me and got a lot of good marks. I myself have 276 in step 2, as well as 260 in step 3. My step 3 marks are the highest in the world right now. So as you can see, it's on the 99th percentile as well. So I gave all of my USMD step exams within 1 year of each other. And before completing my final year, I was able to do step 2 as well. I'm a gold medalist in medicine, pathology, pharmacology, physiology, obstetrics, and gynecology. And I believe a very good foundation for step 1 is very necessary for step 2 and step 3 as well. So that is the thing I kept in mind when I joined King Edward Medical University. So, and I believe that this is a thing which is necessary for my students as well. So now, whenever I teach my students for step 1, I not only prepare them for step 1, but step 2 and step 3 as well. Because if you have a strong basis of step 1, it will not only help you in step 2, but as well as in step 3. So, for example, and for instance, after my step 1, it only took me 3 months to give step 2, and I got 276, which is almost to the 99th percentile. And again, I just prepared 1 month for step 3. Apart from that, I'm a very good researcher as well. I am very keenly interested in research publications and research experiences as well. I have 10 publications right now, and I have 15 citations as well. I did all of that during my medical school, uh, while managing my steps and my professional medical examinations, as well my family responsibilities and business. As far as for my tutoring experience, I have tutored over 50 students on a one-to-one basis. Most of them were getting 210, 220s in the NBMEs in step 2 and step 3. And they got more than 260 and 265 in step 2. And some students got 270 as well. My main method of teaching is a very interactive way of teaching because I believe that one on one teaching and engaging method of teaching is very important to get students good marks. So I encourage questions, I encourage you to participate as well. And I go deep into clinical integration with the basic concepts because you can get the information anywhere in the world at your glance. You can Google anything, you can chat GPT anything. There are a lot of slides, there are a lot of books. But what tutors and mentors lack the most is they do not integrate different topics as well. For example, when you are studying gastroenterology, a lot of people won't tell you how gastroenterology is related to cardiology as well. Because a simple strep bovis infection in the gut or a strep bovis infection in the heart and valves means that you have a colon cancer. This is a very important thing that you need to learn, and how you can integrate that will help you a lot in your steps journey, not only in step 1, 2, 3, as well as in your matching and after when you practice in US, because the ultimate goal is to get a residency in US. So you will get all of that from me.
Okay, thank you so much, Dr. Moaz. So As we already mentioned, that Dr. Moaz is going to be a team of NextGen Usmle. So, Dr. Moaz, can you just please tell our students something about that? As we want to ensure our students that we are going to be here throughout their step journey. Like we do not only promise for step one, but we are going to help them get match, to get to be 100% prepared for the upcoming math cycle, right? So can you just please tell our students something about that? How are we going to help them? What are your strategies, Dr. Moaz, which are going to help our students for that?
Definitely. So, as I have already told you, I will be teaching you step one in such a way that it will not only help you in step one, but step two and step three as well. At the same time, we will focus on your research publications, your volunteer experiences, as well as different certifications. I will get you involved in researches with me as well, and I will get you connected with US mentors and US clinical faculty, because that is the most important thing. Good experiences and good connections with the US faculty and mentors matter the most. And if we have good researches with different US mentors and people with backgrounds of having residency in US, that increases your chances of matching. So we will keep that in mind, and I will not only help you in that, I will help you in researching about different programs, which programs do you need to apply to, which programs are important for you, and help build a CV that matches with your whole profile, your step scores, and then help you with interview preparations as well. Because this is, remember, guys, this is a very long journey. It's not a journey of 1, 2, or 3 months. And you need someone who is experienced in all of this and who can take your hand, walk along with you, and guide you in every step of that. And I am here for you guys, and this next gen tutoring is here with you for the whole time. We'll not only help you in your step one, we are not just here for tutoring you for step one and that's it. Like if I come here, I'll teach you today about gastroenterology and then I go away. No, I'm here to teach you about whole medicine. And I want you to become not only good test takers, but good doctors as well. And this is a thing that is
Thank you
different
so much.
in me from other people. So I'll be here with you for the next 1, 2, 3 years. I'll be helping you in your CVs, your researches, your experiences, your connection in the US as well. And we will go a long way. And I hope to build a long connection with a lot of you in the future.
Okay, thank you so much. So today, Dr. Muaz is going to take our sessions. As you know that today we are about to start from our colon, right? You guys know that, right? So today I'll be also sitting here in the session, and from tomorrow onwards, then I'll be just continuing with Dr. Muaz. As I already promised you guys, so Dr. Muaz is going to be not only here for your step one, but for the step two marathon, which we are about to start, and for our upcoming marathon step one, even for our research. As I just promised you guys that we are going to bring best mentors for your research as well. That's why we have delayed that for some couple of weeks. So that will also be starting soon, and we are working on it. Okay. So yes, Dr. Moss, can you just please start our session today?
Sure. Let me share my screen first.
So if you guys have any questions, you are open to ask Dr. Moaz and Dr. Moaz. Let me just mention. So these are basically our dear students, and I'm here with them since last 3 to 4 months, and some for some students, I'm from last 1 year, I would say. So here we have an environment just like a family. If you guys have any
Okay.
queries, any problems, you can just ask. And okay, let me just okay, yes, Dr. Moaz, please.
So can you see my screen, guys?
Yes.
Yeah.
Yes.
Oh, that's good. So we'll start today from colon. And so gastroenterology is a really important topic in NBMEs and your USMLE step exams, and a lot of topics come from gastroenterology. Even if they are not directly from gastroenterology, a lot of questions, a lot of vignettes, and a lot of diseases will be related to gastroenterology. So it's very important that you cover gastroenterology well, because in step one, a huge portion of it, gastroenterology, will come in your exams. And again, in step two, the whole of general surgery will just cover these topics which we are about to study. So let us start from Hirschsprung disease. So basically, what is Hirschsprung disease? So it is a developmental disorder in which neural crest cells. Okay. So the first thing is, what are neural crest cells? So neural crest cells are the progenitor cells of nervous system which migrate to different areas of the body. And when they migrate to different areas of the body, they form nerves there. So basically, neural crest cells are a part of peripheral nervous system, and they will form a part of your peripheral nervous system, and then they will perform different functions there. And the neural crest cells are derived from ectoderm. This is important because you need to understand the embryology as well for step one. So the neural crest cells come from ectoderm, and then the neural crest cells will migrate into different areas of the body. So what happens in Hirschsprung disease is that the neural crest cells don't migrate properly to your anus. So when the neural crest cells don't migrate properly into the anus of the baby, so there will be no peripheral nerves there. And when there are no peripheral nerves in the gastrointestinal tract, distal gastrointestinal tract, what will happen? So let me ask you a question. What is the role of parasympathetic nerves in the gastrointestinal system? And what is the role of sympathetic nerves in the gastrointestinal system? Anyone?
Parasympathetic will be go through the feces, and the feces will stimulate the peristalsis and the gastric secretions, like gastric acid secretion, and the motility
Exactly.
also stimulate the peristaltic
Exactly.
motility.
So that's
Yes.
so
Mm.
that's the way,
Yes.
second most important thing that the yes, yes.
No, I would just like to add that for hindgut, it's no, it's from the pelvic splanchnic nerves. That's the parasympathetic supply.
Okay, exactly.
Yeah, you are
So the
absolutely
most
right.
important
The
thing that
feces, the feces, sorry, the feces to the stomach and the early part of the duodenum, and this is the parasympathetic. And the parasympathetic, the other one is the pelvic splanchnic. But for the sympathetic, it's the greater and the lesser splanchnic nerve. Sorry, doc. Thank you.
yes, exactly. All of you are right. So basically, the parasympathetic nervous system will cause the gut to contract. And when the gut or gastrointestinal system contracts, the food or the feces will move downward in the system. So when there is no parasympathetic nervous system, there will and no sympathetic there as well. So there will be defective relaxation and peristalsis of the hindgut or rectum and distal sigmoid column. So what will happen there is that the food will get stuck in the hindgut and it won't move down. So what happens when the food gets stuck in the hindgut? It will block the passage of the feces and the food will be stuck there and it will move proximally. So there will be constipation. So that is the first symptom that you will get in your questions. So how the NDME will phrase your question is like that a 5 days old child or a 6 day old child comes to you with his mother and there has been no passage of meconium. So what is now meconium? Meconium is the first tool that a newborn child passes. So this is meconium. Meconium is the first stool that the child will pass. So there will be no meconium, and the mother will complain that the child has passed no stool and there is no meconium, and the abdomen is distended as well. So that is the first sign that you will think that the patient has Hirschsprung disease. So an important question comes here that another disease has the same manifestation and has the same symptoms in which no meconium or no stool will come out of the baby. Anyone has any idea what disease is that?
That's the
Imperforate anus.
meconium ileus.
Ileus. Meconium ileus.
Yes, that is meconium ileus,
Okay.
and
And
that is due
Hirschsprung
to which
disease.
disease?
Mm.
So one is Hirschsprung disease and the second one is cystic fibrosis. So in
Yes.
cystic fibrosis, you will also have no stool and there will be no meconium that will be passed and there will be constipation. So the symptoms of both of these diseases are the same. So how will you differentiate between both of these? I'll tell you again after this. So the second most important thing that you need to remember about Hirschsprung disease is that it is associated with Down syndrome. So why is this important? Because in the question, they will not just give you what is the cause of Hirschsprung disease or what causes Hirschsprung disease. A very favorite question of NDMs and UWorlds and even the exam is that um, the associations of Down syndrome. So they can give you a vignette of Hirschsprung disease, and you diagnose the Hirschsprung disease, and then they ask you what other symptoms or what other associations can be present in this child. So you need to know all the associations of Down syndrome. So the important takeaway point here is whenever you see that a patient has Hirschsprung disease, always think that the patient has Down syndrome. And what are the other associations of Down syndrome? They can give you Alzheimer's, they can give you ALL, acute lymphoblastic leukemia, they can give you they can give you duodenal atresia, they can give you prematurity as well, they can give you heart defects, they can give you atrioventricular septal defects, they can give you a heart murmur as well. So all of these would be the associations of Down syndrome. So keep that in mind. Whenever a patient has Hirschsprung disease, he will have some kind of Down syndrome that you need to keep in mind. So whenever Hirschsprung disease comes or whenever Down syndrome comes, keep Hirschsprung disease in the mind. This is a very important integration, and this integrates to the nervous system, to the cardiology, to the gastroenterology as well, and to the hematology oncology, because they can ask you what kind. They can ask you, a mother comes and the child is not able to pass the stool. So what disease is the child is at risk of in the future? And a lot of students will say, what kind of question is this? And this question is so vague. But this question is not vague. You just have to think that in the next 5 or 10 years, the child will have a problem of acute lymphoblastic leukemia. And what long-term consequences this child will have in the next 40 or 50 years, then the answer would be the child will have Alzheimer, premature Alzheimer disease, or and they can ask you the question, what other symptoms that does the child will have at this point? Then it could be duodenal atresia, or it could be atrioventricular septal defects. Okay, so I already told you why does this happen. It happens due to the failure of the ganglion cells or the neural crest cells that won't migrate into the myenteric and submucosal plexus. And what is myenteric plexus? So myenteric plexus is located between the inner circular and outer longitudinal layers of the muscularis, and it regulates motility. When parasympathetic nerves act on it, it will cause contraction, and when sympathetic nerves act on it, it will cause relaxation. After that, the Meissner's plexus is located just beneath the mucosa, and it causes secretions. What are the clinical features of Hirschsprung disease? So the first one will obviously be, I told you, the child won't be able to pass meconium. And you have to contrast. So remember, guys, whenever you study a disease, always think that what other diseases could have the same symptoms, and how would you be able to differentiate this disease from the other disease? For example, failure to pass the meconium. Whenever in UWorld or in your exam you hear the word failure to pass meconium, you would immediately recognize that there are two diseases that can cause failure to pass meconium. The first one is Hirschsprung disease, and second one is cystic fibrosis. Which so how would you differentiate between cystic fibrosis and Hirschsprung disease? When you do the physical examination on Hirschsprung disease, the rectal vault will be empty and the rectal tone will be increased as well. So that is the main differentiating factor between this and cystic fibrosis. So always look that if the rectal tone is increased or if the rectal wall is empty, then it's Hirschsprung disease. Okay, and then it asks you how would you confirm the diagnosis? So the main way you can confirm the diagnosis is initially you can do an anorectal manometry. First of all, you will do an anorectal manometry. Okay, so what is anorectal manometry? So remember, guys, manometry is very important in GI disorders. When you study the disorders of esophagus and upper GI tract, manometry plays a very important role in differentiating between these different diseases. For example, uh, megacolon, esophageal cancer, such kind of diseases. And here, anorectal manometry will tell you an increased pressure because the food is not being able to pass and the feces are not being able to pass. And what is the confirmatory for this disease? So remember, for every disease in USMLE, first of all, there will be an initial test, which will be a very simple test. And remember, whenever the question asks you what will be the initial test for this disease, you would have to go for the safe, inexpensive, and cheap test. A lot of students have this problem in USMLE these days that in the answers for a question, there will be two options that will be right. For example, uh, a patient comes to you with Hirschsprung disease and they ask you what is the diagnostic step for this disease, and you will be confused that there is anorectal manometry there and rectal section biopsy as well. But remember, guys, remember, if they are asking for the initial step or the confirmatory step, if they are asking for the initial step, remember, go for the safe, inexpensive, and cheap test. Anorectal manometry is a very safe, inexpensive, and cheap test. So first of all, you will go for that, and after that, for confirmatory test, you will go for a biopsy. Biopsies are always the confirmatory test in any diseases because they involve removing a part of the problem. So they are expensive and they are problematic. So always do them later. And the biopsy will reveal lack of ganglion cells. Okay, so let's go for the treatment. So in treatment, the treatment is very simple. You just resect the involved bowel and you staple the bowel, you do an anastomosis, and ganglion cells will be present in the bowel, which is not diseased, and you will just staple it and you will go around it. So that is the main thing about Hirschsprung disease, and that is how they can test you. So let's recap it. First of all, it happens due to the lack of ganglion cells. Secondly, it is associated with Down syndrome. So remember all the associations of Down syndrome. It is a trisomy of chromosome number 21. How you can confirm Down syndrome is it's with karyotyping. Okay. And after that, what are the complications that is associated with the Hirschsprung disease? There are acute lymphoblastic leukemia, as well as low IQ, prematurity, double duodenal atresia, atrioventricular septal defects as well. What are the clinical features? Clinical features will involve failure to pass meconium. Always contrast it with cystic fibrosis because there will be meconium ileus in that as well. But in cystic fibrosis, the rectal tone won't be increased and the rectal vault will be empty at digital rectal exam. So first of all, you do anorectal manometry and then you will do a rectal section biopsy for confirmation. Okay. So let's move to the next topic, colonic diverticula. So what are colonic diverticula? Basically, if this is your colon, so diverticula means the things which has diverted from the normal mucosa. So if this is your colon, what will happen is that this is the mucosa and it diverts outward and it makes this pouch. And this is known as colonic diverticula. It's that simple. Diverticula means a single, and diverticula means a single, and diverticula means a lot of outpoachings. So remember, the important thing is that diverticula are the outpoachings of mucosa and submucosa. Okay, guys. So whenever there is outpoaching, so can you guys tell me how many layers of gut are there present histologically? What are the layers of gastrointestinal tract?
Three.
Three.
We have the
Mucosa,
mucus, the
mucosa,
submucosa, and then
yeah.
the
We have mucosa,
Okay.
submucosa,
then the
serosa,
Folia.
serous,
muscularis. Four.
Folia.
proscolaris, and serous.
Okay.
Serosa and
Exactly. Okay. Okay, so remember, guys, whenever only the first two layers, and NBMEs love to test this concept as well. So when only mucosa and submucosa outpoaches, it is known as a false diverticulum. Okay, and whenever all the four layers outpoach, it will be known as a true diverticulum, or it can also be known as a hernia as well. Okay, so remember the difference between a false diverticulum and a true diverticulum. So colonic diverticula or false diverticulum because only mucosa and some mucosa are outpost. Okay, so they can also give you this question that they can give you the signs and symptoms of colonic diverticula, and then they can ask you what layers of GI tract have been herniated or what layers of GI tract are involved in this. And there will be option of mucosa only, mucosa plus some mucosa, all the four layers of GI tract, or mucosa plus some mucosa plus muscularis. And you guys, you have to know that you have to take mucosa plus some mucosa. So what are the risk factors for colonic diverticula? They love to test this question. So the main risk factor for colonic diverticula are constipation, straining, and low fiber diet. And if you see, these risk factors are interrelated with each other as well, because whenever there will be constipation, there will be straining, and constipation are common in those people who have a low fiber diet. So the most important risk factor is constipation and low fiber diet, which leads to straining. And it is commonly seen in old people because when as you get older, the nerve cells become weaker, and then there is more constipation, which produces a lot more wall stress in the GI tract, and that leads to colonic diverticula. Okay. So another question that they love to ask is that what are the points at which colonic diverticula arise? So they can give you. So first of all, let me tell you the symptoms of colonic diverticula. Usually they are asymptomatic, but the main symptoms that you will see is rectal bleeding, that is hematochezia. Now, guys, as you go into the GI tract, remember two things that it will give you a lot is some kind of bleeding. So whenever there is a question of GI tract, they can just give you a symptom of bleeding, and you will be confused that what every disease has bleeding. So how can I differentiate between every each of these disease? So let's go step by step, and I'll tell you how to differentiate between each bleeding disease. So first of all, colonic diverticula will have some kind of bleed. Okay, so but remember the bleeding of colonic diverticula is profuse. Okay, so it's hematochezia. So hematochezia means a bleeding in the lower GI tract. Can someone tell me what's the differentiating point between lower and upper GI tract?
It's the color of
Color.
the
Color of the
like
stool. Coffee bean color and bright
Acid.
red.
like
Yes.
hematochezia
The
means it will
lab-
be the dark color.
Copper, copy ground,
Yes, exactly.
because of
So if
digestion.
it's below the
Acid
ligament of
mode.
Trites, they can they can ask you what is the standard point. So it's the ligament of Trites. If it's below the ligament of Trites, it will be the lower GI, and above that, it would be the upper GI. And the bleeding of upper GI will be dark in color, it will be maroon in color. And if it's lower GI tract bleeding, it will be fresh in color, it would be red in color. So hematochezia is always red in color. Secondly, it can lead to diverticulitis. So what is diverticulitis? In diverticulitis, so for example, this is your diverticula, and this is the feces which are coming. So what happens is that the feces block this pouch, and when this pouch is blocked, remember this in medicine, whenever a part of body is blocked, even if it's a diverticula, if it's a vessel, if it's anything, a lot of bacteria will get stuck there, a lot of bacteria will be built up at that place, and it will lead to inflammation. And whenever there is inflammation in the body, we term it as itis or titus. So diverticulitis is an inflammation of the diverticula, and that happens when the fecalith material or the feces will block the diverticula. So the important point is, again, I told you that you have to contrast between different diseases, because the most important thing in USMLE is diagnosing the disease. So what are the symptoms of diverticulitis? There will be pain in the left lower quadrant. Another thing that you need to remember for GI tract is what where is the pain in which part of the region, and it will give you a very good idea of what is causing that pain. So if there is acute pain in the left lower quadrant, it most in an old male who has the problem of constipation, it will be diverticulitis. And if the same pain is present in the right lower quadrant, it will be appendicitis. Okay, so remember, if the pain is in left lower quadrant, it will be diverticulitis. There will be fever, there will be pain, there will be some kind of vomiting as well. And it will be the same symptoms like that of appendicitis. And if it is in the left lower quadrant, it will be the diverticulitis. Okay. And third thing is that if the diverticula is inflamed and there is diverticulitis, so what will happen if it is not treated? This diverticula, if this is the skin, it will get ruptured and it will become continuous with the skin. So it can become continuous with the skin, it can become continuous with your bladder. If it becomes continuous with the bladder, we will call it colovesical fistula. Okay, and it can become continuous with the skin, and there will be some kind of fistula as well. So remember, these are the three complications of colonic diverticula, and they can give you all of these symptoms, and they can ask you, what do you think is the most likely place histologically where diverticula, the main point where the problem occurs is at the point where the vasa recta. So what is vasa recta? Vasa recta are blood vessels that forms an anastomosis, and they pierce the muscularis propria, and then they supply the colon. So where the vasa recta transverses the muscularis layer of GI, the colonic wall is very weak there. So that is the point that where the verticula will occur, and this is most common in the sigmoid colon. So that is how you will know about colonic diverticula. So let's move on to angiodysplasia. What is angiodysplasia? Basically, angiodysplasia means some kind of problem, congenital problem, in which the blood vessels or the structure is not properly formed. And angio means vessel. So always go and look toward the etymology of the disease. So angio means vessels, and dysplasia means that they are not being properly formed. So endodysplasia means a problem where vessels are not properly formed. Okay, so it's a malformation of mucosal and submucosal vessels. Okay, so what are the symptoms of angiodysplasia? The most important features of angiodysplasia are again hematochezia. So, how would you differentiate between the bleeding of colonic diverticula versus the bleeding of angiodysplasia? Can anyone tell me? Can anyone tell me that?
Doctor, your voice is
You
actually
were
breaking, so we
breaking.
cannot hear. We cannot hear what you said.
Okay. Um, okay. So I'm asking, can someone tell me what's the difference between the bleeding of colonic diverticula as compared to the bleeding of angiodysplasia?
I
Presence of
think
Can
in
mucus
you
the
guys
also.
hear me?
in the colonic, yeah, I think in the colonic diverticular, it will be happening when he does training and he will having constipation and like this. But in angiodysplasia, it can happen at any time, and
In
it will be usually
angiodys
with the colonic
Okay.
diverticular, it will be mixed with I think with the stool, something like that. Most. Thank you.
angiodysplasia will also present with other
Mucus.
symptoms
Okay.
like heart or cardiac.
Okay. Okay, so let me tell you. This was a thing that always confused me a lot because I could not differentiate between the bleeding of all of these disorders. So, guys, the bleeding of colonic diverticula is due to vasa recta. Okay, so the vasa recta are basically arteries, are the branches of arteries. And remember, the bleeding of arteries, the blood flow in arteries is always higher than that of capillaries and veins. So when the problem is in arteries and the arteries are bleeding, the bleeding will be profuse and high. So the bleeding of colonic diverticula will be profuse and it will be painless. So they can give you a scenario that a person presents with painless, profuse red bleeding, and you would always think that the problem is in some kind of artery, and you know that when there is a problem in artery and it is painless, then it will be colonic diverticular. But the bleeding of angiodysplasia is due to capillary beds. Okay, guys, so when the bleeding is due to capillary beds, the bleeding will be very slow and it won't be profuse bleeding. The patient will complain of bleeding, which is very slow, and the patient will say that the bleeding is coming for 1 or 2 months. But the bleeding of colonic diverticula will be acute. So always look for the time duration of the symptoms as well. So if the bleeding is profuse, acute, and presents in 1 or 2 days, and it is red, then it will be colonic diverticular. But if the bleeding is profuse, bleeding is slow and presents over a period of 1 or 2 months, then it will be angiodysplasia. Okay. So another thing that you need to know are the associations of angiodysplasia. So angiodysplasia are associated with three things. They love to test this concept as well. First of all, it is associated with von Willebrand disease. Second, it is associated with end stage renal disease. And thirdly, it is associated with aortic stenosis. So they can give you a question that a person was 83 years old of age and he has a murmur in the right upper border of heart or the right second intercostal space that radiates through the carotids, and he has bleeding for the last 5 days. So, what will be the most likely cause of his bleeding? The most likely cause of his bleeding would be angiodysplasia. Or they can give you a question that a person comes to you with bleeding for the last 1 month, and there is a malformation of submucosal capillary beds on endoscopy or colonoscopy. And they will ask you, what other screenings do you want to do in this older person? So we will do you, and they will give you one of three options. Either they will give you von Willebrand disease, they can give you end-stage renal disease, or they can give you aortic stenosis. So always keep these associations in mind, because NBMEs love to test these kind of associations. Nowadays, NBMEs know that you will know what are the causes of angiodysplasia, what are the symptoms of angiodysplasia. So they won't give you these simple questions, because in real life you have to integrate different concepts and different diseases. So they will give you this thing as here as well. Or if they want to make it more confusing, they could give you a 85-year-old male comes to you with bleeding, and on endoscopy or colonoscopy, there is malformation of submucosal capillary beds. There will be what other problems, what other pathophysiological problems will be present in this person, and then they could give you the pathophysiology of von Willebrand disease. And what's the pathophysiology of von Willebrand disease? Can you tell me, anyone?
There will
It's
be
a platelet
there will be failure of the attachment of the platelets to the subendothelial wall. Okay.
Exactly. So they will give you failure of platelets to attach to the
Platelets.
subendothelial or subepithelial wall, and platelets. So then a lot of students will say, a lot of people will say, we cannot understand what the question was, because the question was about gastrointestinal tract, and the options were related to hematology, oncology, or kidney diseases or heart diseases. But that is how they want to test you. So let's go to the fourth disease, which is hereditary hemorrhagic telangiectasias. So, what are hereditary hemorrhagic telangiectasias? So, first of all, this one other thing that NBMs love to do is that they try alternate names for a disease. You will you have heard the name hereditary hemorrhagic telangiectasias, but they won't give you this name in the question. They will give you Osler Webb Rendo syndrome. They won't give you that code. They will just give you Osler-Weber syndrome, and you guys will say, what kind of disease is this? So, what happens in Osler-Weber syndrome? So, if there is a malformation of capillaries in whole of GI tract, not just the colon, but the whole of GI tract and other organs as well, then it is known as Osler-Weber syndrome or hereditary hemorrhagic telangiectasias. Basically, what happens in this disease is there are abnormal arteriovenous fistulas. So, if this is the artery and this is the vein, a fistula will form between them here. And this will be known as hereditary hemorrhagic telangiectasias, because these fistulas will be very delicate and they will burst and they will cause bleeding. So, where can you find these fistulas in Oster-Weber syndrome? They will be present in mouth. Okay, they will be present in mouth, as well as they will be present in lungs as well, in your kidneys as well. So if a person complains of bleeding which is red in color, and at the same time the patient has bleeding from the lungs, just think of hereditary hemorrhagic telangiectasias, and the patient will complain that he has this disease for the past 1 year or so, or for the past 10 years or so. So then you will think about hereditary hemorrhagic telangiectasias. Okay, wait a second. Let me show you a picture of hereditary hemorrhagic telangiectasias. Helen. Oh my God. Osler. Zoom down. Hmm. Okay, so guys, this is the picture for Osler-Weber syndrome. As you can see, there will be these kind of malformations, and they will be present on the mouth. They will be present on whole of the body. So if they give you a picture of this and they ask you that there's in bleeding in GI tract as well, then just take off Osler-Weber syndrome or hereditary hemorrhagic telangiectasias. Another most important question is that what kind of complications can Osler-Weber syndrome cause? So the three most important complications. Number one, it can cause GI bleeding. Secondly, it can cause bleeding in the lungs or pulmonary hemorrhage. Thirdly, these AV malformations will be present in your brain as well, so they can cause intracranial hemorrhage. And the most common cause of death will be the intracranial hemorrhage, and uh, arteriovenous malformations will be present. And what is the mode of inheritance of this disease? It will be autosomal dominant. So remember, telangiectasias will be present. And again, here you need to contrast between three different diseases here. The first disease that you need to contrast is hereditary hemorrhagic telangiectasias. Secondly, these same kind of lesions would be present in two other diseases as well. The another disease that will have telangiectasias is ataxia telangiectasia mutasa. When we will study about immunology, you will learn about this disease, ataxia telangiectasia mucosa. What happens in disease, ATM disease, is that a DNA repair gene is absent and it will cause telangiectasias in different part of the body. What is different between this disease and the hereditary hemorrhagic telangiectasias is that in ataxia telangiectasia mucosa, mucosa, there will be ataxia of the body. The patient will have some kind of balance problems. So if your vignette says that the patient has telangiectasias and some balance problems, go with ataxia telangiectasia mutasa. And what are the complications of ataxia telangiectasia mutasa? In that disease, there will be risk of cancers. The risk of skin cancers will be increased in that disease, and risk of lymphomas as well. What are the complications of hereditary hemorrhagic telangiectasias? There will be increased risk of intracranial and pulmonary bleeding in this kind of problems. And another disease in which there is uh, patches on the mouth, it's Pete's-Jeghers syndrome. This is the most favorite thing, which is which the NVM is love to test. So in Pete's-Jeghers syndrome, so if you go for the Pete's-Jeghers syndrome, there will be blackish lesions on the mouth. In hereditary hemorrhagic telangiectasias, the lesions will be red in color. But if the same lesions are blackish or brownish in color and they are present on the mouth, then it will be Pete's-Jeghers syndrome. And in that disease, there are mucosal lesions on the mouth which are black or brown in color. And at the same time, there are polyps in the gastrointestinal tract or hematomas in the gastrointestinal tract that lead to cancer. So always look out for these three diseases whenever there is some kind of lesion in the gastrointestinal tract or on the mouth. Okay, let's go on to the next disease. Anyone has any question till now?
No, thank you.
No.
No, doc, we are really enjoying it.
Join it. Thank you.
Okay. Okay, so let's move on to ischemic colitis. So what is ischemic colitis? As the name can say, I always told you that itis means inflammation. So colitis means an inflammation of the colon, and ischemic means due to some kind of ischemia. And what are the 2 points where the damage to colon will happen? Remember again, this is a very high yield point, and we must love to test this. That what are the points where ischemic colitis happens? So the way the NVM is frame the question is, first of all, they will give you information and symptoms, and you have to diagnose the disease. And then they will ask you about some kind of histology or the area or the complication of the disease. So the most two common places where it happens is at the splenic flexure of the colon. This is the one. And the second is the sigmoid colon
Sigmoid.
at the area of sigmoid. Yes. So first of all, why it happens at the splenic flexure? Because at the splenic flexure, there is a lack of anastomosis. So there is a what is a watershed area? A watershed area is such an area where there's a lack of anastomosis and only one vessel is supplying the area. So at this point, only superior mesenteric artery is supplying the colon. So if the superior mesenteric artery gets blocked, there will be ischemic colitis. And again, at the sigmoid colon, only inferior mesenteric artery is supplying the colon, and then at that point, that will cause ischemic colitis. What is the most common cause of ischemic colitis? One is atherosclerosis, and the second is whenever there is some kind of GI surgery. So the most common vignette is that a patient comes to you and he had a gastrointestinal surgery, or he had a surgery of back for some problem, or he has a surgery of ruptured aortic aneurysm, abdominal aortic aneurysm, and now he presents with bleeding and pain and bloody diarrhea. So what is the likely diagnosis? So again, guys, It's just about the bleeding. Whenever a question of colon comes, there will be some kind of bleeding. You have to know what kind of bleeding it is. If the bleeding is profuse, painless, and acute, it is colonic diverticular. If the bleeding is for 1 or 2 months and it is very slow, and the patient is old and he has von Willebrand disease and stage renal disease, CKD, then the problem is angiodysplasia. If the bleeding is also occurring in the lungs at the same time and in the GI as well, then it will be hereditary hemorrhagic telangiectasia. If the bleeding has some kind of black mucosal patches on your lips as well, then it would be Pete's-Jeghers syndrome. And if the bleeding occurred after some kind of abdominal surgery, then the bleeding will be due to ischemic colitis. So these are the simple things that you have to know. And what are the points where ischemic colitis is common? So there are 2 points. The first point is splenic flexure of the colon. The second point is sigmoid flexure of the colon. So that's up with the bleeding. Now let's move on to the irritable bowel syndrome. What is irritable bowel syndrome? So irritable bowel syndrome is a simple disease in which there will be constipation that will alternate with diarrhea. Okay, and there will be pain in the abdomen, and the pain will improve when the patient defecates. So this is a classic telltale sign of irritable bowel syndrome, that the patient will have some kind of pain, and the pain, abdominal pain, will disappear when the patients defecate. And it is commonly seen in middle-aged females. Why is it seen in females? Does anyone know about this? Okay, so remember that irritable bowel syndrome has an association with nervousness or some kind of psychological issue. So, if normally females are most in NBMEs and UWorld style questions, females are more nervous, so they will have more irritable bowel syndrome as compared to men. So these kind of problems, irritable bowel syndrome, will be more common in females. What are the other comorbids that they can give you? They can give you that the patient has some kind of depression, the patient has some kind of psychological problem, the patient is nervous, the patient has some kind of exams, the patient is going through a nervous stressor, the patient had a death of one of her family members, of his family members. That will be the cause of irritable bowel syndrome. So, what happens? So, we don't know about any pathologic changes in the irritable bowel syndrome, but it just happens due to the disturbed intestinal motility. What can improve irritable bowel syndrome? Pathoma usually says dietary fiber, but remember, you have to treat the symptoms of irritable bowel syndrome. They can give you that a person comes to you of irritable bowel syndrome, diagnosed irritable bowel syndrome with diarrhea. So, what are the things that you can give to this person? So, you will give him some kind of or her some kind of antidiarrheal drugs, and then they will ask you the mechanism of the drug that you have given to that person. So, maybe you have given that person loperamide. So, loperamide acts on mu opioid receptors of the colon, and that will slow the intestinal motility. They can give you the patient suffers from cramps and abdominal pain. So you have to see that cramps and increased contractility of the intestine or colon or small intestine is due to parasympathetic stimulation. Because parasympathetic stimulation causes the gut to contract. So you have to give some kind of empty parasympathetic drug, which is known as parasympatholytic drugs. So you give that person some kind of parasympatholytic drugs, and the person will improve. But always remember the comorbs of irritable bowel syndrome. Remember, if there is diarrhea, we will give antidiarrheals. If there is constipation, we will give fibers, laxatives. What are the different kinds of laxatives that we will cover in the pharmacology? Okay. Let move on. Let us move on to colonic polyps. Okay. So what are
So,
polyps?
doctor, there
It's
is one
again
more
NVME.
disease. Sorry to interrupt you.
Okay.
So,
Which
doctor,
one?
there is one more disease that is called microscopic colitis. So, it can be differential with that because
Yes.
this also occurs in mid-age women, or
Yes,
that's not high
exactly.
yield.
So yes, but okay. So I will go on microscopic colitis. I think after polyps there will be microscopic colitis, and then I'll tell you about microscopic colitis. But one important thing about irritable bowel syndrome is there are some red flags. Remember, When there are some red flags of GI disorders, you can't say that it is irritable bowel syndrome. And they love to ask this as well, and it is very high yield. If there is any kind of bleeding, if the symptoms are at night, if the symptoms cause any kind of weight loss, then it won't be irritable bowel syndrome. Then it will be some other kind of disease that you have to investigate in that person. And then you will order the relevant test. If there is any bleeding and it occurs at night or there is weight loss, then it is not irritable bowel syndrome. It is some kind of other disease that you need to know about. Okay, but she just told me about microscopic colitis. So in microscopic colitis, the main differentiating feature is that the pain won't improve with defecation, and there will be diarrhea that causes weight loss in microscopic colitis. So remember, in irritable bowel syndrome, there won't be any weight loss, and the pain will improve with defecation. So let us move on to the colonic polyps. So what are polyps? Remember, polyps is a very high yield topic. They love to test this in their exam. In your exam, there will be a definite question on polyps. So what are polyps? So basically, polyps are the raised protrusions of mucosa. So it is the exact opposite of diverticula, because in diverticula there is an outpouching. This is a diverticula. In polyps, there will be a raised area inwards like this. This is known as a polyp. Okay, so it is a protrusion of mucosa. So what are the types of polyps? The most important, the most benign types are hyperplastic polyps. So hyperplastic polyps, there will be simple hyperplasia of the glands. There are glands here in the submucosa. These glands will get thicker and there will be hyperplasia, and then a polyp will form. uh, they can ask you about there was a polyp. We did a colonoscopy, we did a biopsy, and it classically it showed up serrated appearance on the microscopy. So, what kind of polyp is that? That polyp is a hyperplastic polyp. It is a benign polyp with no malignant potential. They can again ask you, does it cause any increased risk of malignancy? The answer will be no. It won't cause any increased risk of uh, like cancer. Another important thing is, how do we diagnose polyps? Can someone tell me?
Colonoscopy.
So
Colonoscopy.
exactly.
Colonoscopy.
So we diagnose polyps on colonoscopy, and we have to start the colonoscopy at the age of 45 years. So 45 is the standard age for colonoscopy, and we repeat it in every 10 years in normal people. So even if we found a hyperplastic polyp that has no malignant potential and that has a classical serrated appearance, then we won't do an increased colonoscopy. The colonoscopy will be repeated at 10 years straight. The second most common type are adenomatous polyps. Adenomatous polyps is due to some kind of malignant proliferation. Okay. These are benign, but it can be pre-malignant and it can cause carcinoma due to adenoma carcinoma sequence. When we study colon cancer, I'll go on to the adenoma carcinoma sequence and how does it happen. Okay, so uh, I'll tell you about adenoma carcinoma sequence in the like colon cancer. We can skip this topic. Okay, so screening for polyps is, again, I told you, it is performed by colonoscopy and fecal occult blood. We can test it using fecal occult blood, but the standard is colonoscopy. And in the NBM is the right answer will always be colonoscopy and not the fecal occult blood test. Okay, so we have to remove the polyps as soon as we get them. Adenomatous, whenever you say, yeah, adenomatous polyps or neoplastic polyp, we remove them and we do increased surveillance. So we have to repeat the colonoscopy after 1 year. But if we see a hyperplastic polyp, we don't have to repeat the colonoscopy after 1 year. We can do a colonoscopy after 10 years. Okay. So the another thing, important thing is, on colonoscopy, you cannot differentiate between a hyperplastic and adenomatous polyp. Both of them will be identical. Okay, the difference that you can see is on microscopy. Okay, so in microscopic, if there is serrated appearance, it will be a hyperplastic polyp, and if there is not a serrated appearance, it won't be a hyperplastic polyp, it will be an adenomatous polyp. Now let's go on to familiar adenomatous polyposis syndrome, FAP syndrome. Okay, so what happens in FAP syndrome? So first of all, remember, it is an autosomal dominant disease, and it happens due to APC gene, which is located on the chromosome number 5. Okay, so what happens when there is a problem of APC gene? So what kind of gene is a APC gene? First of all, remember this. Is it an oncogene or tumor suppressor?
Tumor
I think
suppressor.
Can
it's
anyone remember?
Tumor suppressor gene.
Exactly. Yes, it's a
Tumor
tumor
suppressor.
suppressor gene. So APC is a tumor suppressor gene, and when a mutation in APC gene occurs, so remember, whenever there is a tumor suppressor gene, there needs to be two hits. So whenever there are two hits of APC gene, tumor suppressor function is lost, and increased polyps will be formed throughout the colon and rectum. So this is known as familial adenomatous polyposis. At the age of 17, so the question will be like that a patient has his father who had colon cancer at the age of 35, and his grandfather has colon cancer as well. And now this child presents to you at 18 age, and we do a colonoscopy, and we find a lot of polyps in these children. What should we do? So in these patients, we have to remove all of those polyps, and we have to remove the colon as well. So this is known as prophylactic colectomy, prophylactic protocolectomy. So prophylactic means that you do it before the colon gets a cancer, and protocolectomy you have means that you have to remove all of the colon as well. Otherwise, all of the patients will get carcinoma by the age of 40. Another important thing that you need to remember is that what is the screening protocol for colonoscopy in these patients? So basically, in these patients, you have to do colonoscopy starting at the age of 15. So at the age of 15, you have to do colonoscopy in these patients on an yearly basis. In normal people, we do colonoscopy at the age of 45 at the 10 years gap. But in these people, you have to do colonoscopy at the age of 15 every year. Now, what are the other syndromes that are associated with familial adenomatous polyposis? First of all, it's the Gardner syndrome. So what happens in Gardner syndrome is that there will be osteomas. So osteoma is a benign tumor of face. So just remember this guy. If there are polyps and there is a black mucosal patch on your lips, I told you before, it is known as Pete's-Jeghers syndrome. Okay. If there is a polyp and there are osteomas or bone tumors in the face, then it will be Gardner syndrome. Okay. So, and if there is polyps and at the same time the patient has some kind of CNS tumor like medulloblastoma or some kind of astrocytoma, then the patient will have Turcot syndrome. These are the small associations that you need to remember. They can give you a question that a patient of age 18 years comes to you with a family history of colon cancer, but this patient has no colon cancer and he has a medulloblastoma in the fourth ventricle of the brain. So, what other disease does this patient can have? So you have to recognize that this patient's father had colon cancer and he has medulloblastoma at such young age. That means he has some kind of hereditary problem. So what hereditary problem involves skull, brain tumors and colon cancer history, and that will be Charcot syndrome. So uh, first of all, let's do Pete's-Jeghers syndrome. Again, Pete's-Jeghers syndromes mean hematomous polyps throughout the GI tract. And the most important other thing includes it is that it causes mucocutaneous hyperpigmentation, which I have just shown you. It is brown or black in color, and it causes increased risk of colorectal, breast, and gynecologic cancer. So remember again, guys, if they give you a patient with black or brown mucosal patches on the mouth, they can ask you what increased cancers that this person can have. So remember, it is not only in the colon cancers, but as well as the breast cancer, uterine cancer, cervical cancer, and ovarian cancer as well. Juvenile polyps. What are juvenile polyps? Juvenile polyps are present in children's, uh, and there are large number of polyps, and that can cause cancer. But remember, the cancer risk is not so much as increased as compared to like familial adenomatous polyposis. And an important differentiating factor between this and juvenile polyps and familial adenomatous polyposis is that in familial adenomatous polyposis, the polyps comes at the age of 10 or more. So if the patient is in his teens, like 10, 11, 12, 12, 13, 14, 15, then it will be familial adenomatous polyposis. But if the patient comes at the age of less than 5 years and it is a children, then it will be a solitary polyps and it will be a juvenile polyps. And it has increased risk of cancer, but it is not so much as increased as compared to familial adenomatous polyposis. I think that covers it for today. And tomorrow we can start from colorectal cancer, and then we'll go after colorectal cancers. And I think the colon will be completed.
Excuse me, doctor.
Yes.
I just wanted to ask you something. I'm sorry, at the moment the voice was breaking. So for the FAP, what you said that the colonoscopy we're gonna start at the age of
15. 15.
okay, and then every 1 year.
So, yes, then every 1 year.
Thank you.
Any other question?
So, doctor, isn't it like if the father has a disease at 50 years, so you should start screening 5 years before or 10 years, like prophylactically?
Exactly. When we go on to the colorectal cancer, after that I will tell you the screening colonoscopy screening guidelines about what if the father has cancer at 50, at 60, and then I will tell you about microsatellite instability and as well, and what screening protocols are in that as well. So I'll tell you about all of that about in the next section.
Miss, I have a question.
Yes.
Yeah, please, how do you describe the bleeding of angiodysplasia? You say it's profuse and what
No, no.
again?
Okay, so the bleeding of colonic diverticula will be profuse, red, and painless. These three words are used to, so they can interchange the words with something other. Heavy, heavy red, heavy fresh bleed, heavy painless fresh bleed, or they can give you heavy fresh bleed, which is not causing any pain. And the bleeding of angiodysplasia would be slow, and it would be over a period of days versus as compared to an acute bleeding of colonic diverticula. So remember, the bleeding of angiodysplasia is very slow, and the bleeding of colonic diverticula is very profuse and fast.
Okay, thank you.
No worries.
Thank you, Doctor. Can I ask something not related to education, if you don't mind?
Yes.
Yeah, as regards, Batoma. Actually, I read the first three chapters of it. What's your recommendation? Shall we read it all? Or,
I
I
think.
mean, besides first aid and your work. Thank you.
Can you repeat your question? I did not get it.
Yeah, I'm just speaking about Batoma. Is it important to read this Batoma, or we can, just confine to the word and the first aid?
I think
What do you think?
UWorld and first aid, honestly, UWorld and first aid are more than enough. You do not need to combine pathoma, but you need some kind of pathology resource. First aid is fine, pathoma is fine as well. It's a personal preference, but you can go with first aid and UWorld as well. It's known as the FAP method, first aid and UWorld. So it's as good as pathoma.
Thank you.
Thank you.
Hi, doctor. I have one question.
Yes.
So I am facing problem to diagnose it with histopathology figure. So how could I improve, or there is any technique then I can actually distinguish and diagnose the disease?
Okay, so after like when we finish the colorectal cancer tomorrow, I will have some kind of images, like 100 or 200 images of different histopathologies and different diseases as well. And I'll tell you how to diagnose the disease using histopathologies, because first I told you, first you have to go through the basics, that you have to understand what is the mucosa, what is the submucosa, what are different kind of nerve cells, what are the different kind of glands. I'll give you an overview on that, I think tomorrow or a day after that. I will just hold a complete class on histopathologies, and that way you can get a good grip on that. If you want to still get a good grip, whenever you see a disease and a histopathology, just whenever you see a disease, just go to Google and like search histopathology of hyperplastic polyp and see 15 or 20 images of that. And then if you want to see search histopathology of adenomatous polyp, and then see 15 or 20 images of that as well. When you see a lot of images, you will get to know the pattern.
Thank you so much for your
No
advice.
worries.
So, doctor, is it really important to know the histopath, like just by looking at the slides, because it's very confusing, and sometimes we rely on the scenario or the case presentation to answer those things. So, and with this limited time and with so much information, so just give us the things which we can just do in the exams or NBME related.
Think there will be 3 or 4 questions in the exam that will be related only to the histopathology, and you will need the histopathology. But I think at max it will take you 1 or 2 hours to get the basics of histopathology, and then it won't be a problem for you anymore. It sounds tough that the histopathology is very tough, but when you get a good grip of it, what is the basic structures, what are the basic glands, what are the basic epithelial cells, mucosa, submucosa, then it will be very easy for you, and then you will wish there were more questions of histopathology in your exam.
Okay, thank you, sir.
Okay, so now I have to go. I have another class. So if you have any questions, we can answer that tomorrow. Okay.
Thank you,
Thank you
Doctor.
so
So it was a
Yes,
great
doctor.
lecture. Appreciate it. Thank
Thank
you.
you.
Thank
Thank you for your awesome class.
you.
Thank you.
It was really awesome.
Thank you.
Yes.
Thank you.